Hello, everybody. Thank you for joining again. We'll begin in a few minutes. Well, good morning, everybody. Thank you for coming again. We have so let's see. We'll go ahead and get started. So we'll cover the posterior fossa veins today. Big topic, a lot of stuff in there. We'll give a lecture, and then if anybody has cases, please go ahead. Let us know. You can use the Zoom chat, or you could unmute yourself and speak. If you have any questions, there'll be obviously opportunities during the lecture, and then you could we'll talk afterwards. Couple of announcements, so please keep yourself muted unless you're talking because of the background noise. I hope we'll try to do this thing today with the stereo glasses, something like this. If you have them, great. If you don't, you could still look at it. It works either way. But if you have them, you might see something a little bit different. Let's see. We talk about Yun Peng Wang a lot, but you know, I don't think ever enough. So just this is a lecture that we gave last year at the in-person Banana. So I just want to give him a shout out again. A lot of the stuff that we have kind of comes out of his work and everything that came after that. What else? We have a list. If you go to the BANANAZ page, you could sign up for we're generating a kind of like a listserv or whatever, like a newsletter that we'll be starting up to kind of keep everybody posted on what's going on. Okay, so let's see. That's Yoon. That's his artwork, by the way. He's quite an accomplished artist as well. So the posterior fossa veins can be like a challenging topic. I think the approach to that is in many ways similar to how we approach a lot of other things, like the same principles apply. So one of the principles is that veins are like rivers. You know, the vein is as big as the sum total of all the streams that have joined it. That's always something important to keep in mind. And number one. Number two is this concept that we've emphasized throughout these like Venus lectures that we've had. Concept of balance, like veins can be interconnected or not. Some can be dominant or not. And I think the same thing applies for posterior fossa veins. Use the same approach. So here's like a lateral view of somebody who has like a very balanced distribution. Here's the trillard, Sylvian veins, you know, Labbe. And you see how they're interconnected over here. Of course, that doesn't have to be that way. Veins are like fingerprints. Everybody's unique. Here's somebody who now, this sign here, you have that, see those circles at the bottom? And put on the glasses. And you can see the stuff in 3D. It takes a little bit of time to get used to it if you haven't worn them, you haven't tried them on. Now the red goes on the left, so remember that. Red is on left, otherwise you see it backwards, which is fine, like medial to lateral, lateral to medial, whatever. So here you see like somebody, it's one individual. Here's like a dominant Rolando here, and here's a dominant trillard, here's a big basal vein. You know, we'll get into the intricacies of like stereo projections in a little bit, but I hope, like, for example, you can see that the image on the right is a little bit like too deep, right? Like if you look at it, you see how like the superficial veins are coming out at you a lot, more than they should. And so that has something to do with like, that's one of the kind of things we can vary. Here's another one, right? So this is not posterior fossa veins, but this just shows how you apply the same ideas like that you would show. Here's a superficial system lecture, dominant superficial Sylvian veins in this individual over here. And this, of course, is a dominant vein of Labbe. So you get the idea, right? Now, the same things, this is the classic view of posterior fossa veins, is that this is from Yunpeng Wang too. And that's the classic view. And that's just essentially looking at this diagram, right? And thinking about it in terms of these groups or confluences, which are basically places where venous blood is like tends to go and tends to coalesce and connect. So you have the superior or the galenic group. Obviously, that's where like some, you know, veins that you may know of are going to be draining. The basal vein, then this other like kind of like lateral mesencephalic group can go there as well into the basal vein or someplace else, down to the petrosal sinus, precentral cerebellar vein, these Vermean veins, some tectal plate veins. So basically like stuff that's going to come up here and drain into the galen. Anteriorly, or the petrosal group, is the petrosal vein, right? So the petrosal vein is going to collect brainstem, lateral mesencephalic, some of these anterior cerebellar surface veins. And then lastly is the posterior group or the torcular group. That's going to, you know, whatever is going to go over there is like sort of inferior posterior cerebellar veins, inferior Vermean veins, and so forth. So that's the way to look at it. That's the way we've looked at it for a long time. And I think that's super useful. And that's where the concept of the balance comes from. So like somebody might have a very dominant petrosal group or whatever, any one of these. Okay. This is a picture from Roten. So this idea is not unique to like, you know, the surgical literature also has that prominently adopted. The names, whatever, like you just have to know where they are. because they're going to go by different names. There's a surgical nomenclature, like Roten's nomenclature, and Yun's, for example, can be a little different. This is a table from the Neurangio website. You can find it over there if you, whatever, if you need to care about these different names. But just you kind of have to be comfortable with whatever stuff is called. Okay, so that's number one. Number two, again, we're thinking like in terms of like thinking, like applying a method to this. So one method is this idea of like balance, looking overall at like what's dominant. The other is number one, so using cross-sectional imaging. We'll talk a lot about that. We'll show some examples. And that's something that like Yun's generation didn't have. We have like superb cross-sectional imaging. We have amazing MRs. We have venously contaminated CTAs or CTVs. And you could use these to like great advantage to understand where the veins are. If you're learning about veins, I think the best way to learn them is to put up, if you're doing angiographies, you put up an angio on one side, you put whatever your cross-sectional thing is on the other side, and you just look. You look for same structures, you look for locations. That's the way to learn. And you understand the relationships. Of course, veins are much, kind of hug the surface of the brain much more than the arteries do. So in terms of understanding what like the brain structures are relative to the veins, that works better than the arteries most of the time. And it's important to study that. And it's also like, so in terms of that, these numbers 1, 2, 3 are the numbers of things that we generally teach in our training for people what to look for. So when you look at, say, a lateral angiogram of venous phase of vertebrobasilar injection, what you want to try to do in your mind is to kind of try to understand where the brain is. Like you want to look at these veins and say, okay, where is the outline of the brainstem? Can I look at these veins and understand where the brainstem is? Can I look and understand where the cerebellum is? That's number 2. And number 3 is going to be the fourth ventricle. So if you can kind of put these structures in your mind, overlay them on the angiogram or the venogram, you're going to be like a long ways towards understanding these things. Just some examples of, like, say, this is a 7 Tesla MR, some crazy resolutions that you can get over here, of course. And so here you see, the typical veins that we look for. This is the lateral mesencephalic vein. You see how that's the mesencephalon, and it's typically running in this location. Here's the precentral cerebellar vein, historically important, unpaired usually vein behind the tectal plate. And that is an important structure too. So just an example of how that works. Here's the coronal, same subject, same 7 Tesla MRI. Again, precentral cerebellar vein, splitting into these veins that running along, so that goes down to the superior cerebellar peduncles, each one of those. Yep, more of the same. Okay, so you get the idea. All right, so I guess we'll take a tiny break. The stereo, I just don't know like where to insert this, but if you can humor me for a second. We use a lot of stereo. So this is just a stereo camera. The whole stereoscopy idea is based on the fact that we have obviously like stereoscopic vision. So this camera is basically, it's trying to reproduce what we have with 2 eyes. So most of us have like convergent stereoscopic vision. You're looking at the same structure from slightly different angles, and that information, the difference in that information is used by the brain to produce a sense of depth, right? So stereophotography is based on that principle. You take like 2 lenses, or you take a camera, you move it slightly to the side, take a picture, move it as far as your interpupillary distance might be, or something close, take another picture. And so you produce these 2 images, which are just slightly different. And then there's all kinds of different ways of putting them together to achieve the stereoscopy effect, which is an illusion, right? Stereoscopy is an illusion. You could use these glasses, the anaglyph glasses. There's all kinds of ways. You go to the movies, you get different kinds of glasses. All of these things have different advantages and disadvantages. Some of them require special screens, but the trade-off for that is the colors are better. And so there's like a lot of history of using stereoscopy in medicine too. Roten's lectures, for those of you that have seen them, a lot of them are stereo lectures using anaglyph glasses as well. So yeah, you could put these on. This is like a NASA picture, a stereo image from Mars in this particular instance. You see how the images are separated by a lot, right? Like the red and the blue are like a lot separated. So the separation of the images has to do with how much like difference is between the images. And that creates a sense of depth, like how much depth there is. There's a variable sense of depth that can be produced, like it can be too deep or too shallow. That's one of the limitations. That's what limits like this approach in terms of like navigation, like stereoscopic navigation for your treatment purposes. So you can Google all these things. There's all kinds of pictures out there on Google, including one of ours right here, one of the higher ones, because I guess we use a lot of stereo in medicine for us. How do you make stereo pictures? A lot of you know how to do this already. If you don't, it's not that hard. It's basically you take your subject, you take an image. Hopefully your subject is relatively still. They're either under anesthesia or they don't have to thrash around too much. And then what you do is you tilt your camera or cameras 2 to 6 degrees. How many degrees depends on how much depth you're going to get out of it. So the more degrees, the more depth. So the tilting of the cameras is equivalent to kind of moving what would be like if you're taking a photograph, that would be like a difference in terms of perspective. And so you get 2 sets of images. You put them side by side. This is an older article. This has been like, there used to be actual units, like X-ray units that had 2 detectors that you could make stereo images kind of easier. But this is like an older stereo pair. One of ours, right? So you have these pictures. This is a cross-eye view. Some of you, if you're able to like cross your eyes, there's another way of doing it. Like the most basic way is crossing your eyes, looking at the left image with the right eye and vice versa. Now, when you get that, when you do that, you have an illusion of stereoscopy. That's how we do it. Like when you're doing it in real time, you take these pictures, you put one as a reference, you put one like next to it, and then you look at them that way. It's particularly helpful actually for the veins when you're trying to see which veins are deep, which are superficial. If you're not sure, that's one way to do it. And that's the same picture. If you use your glasses, you can see that there is like a sense of depth over here, right? So anyway, so like we use that a lot in posterior fossa. You can make it even fancier. You could use, we talk about making the arterial phase as you image, and so you have like a double mask or even a triple mask here in the image on the left. You can have all kinds of depths. This is like a nice demonstration of like the inferior extent of the cavernous sinus over here, some of the drainage into the pterygopalatine venous plexus. That's a very common place where that structure tends to drain. Okay, so here's a posterior fossa. Getting back to that. If you put your glasses on, if you have them, if you don't, you can still see it. It's a little bit blurred, but I don't think you really lose that much in terms of understanding it. So basically, here's a typical like frontal lateral view of posterior fossa injection. And you can kind of want to, again, we're going to apply the same principles. If we go forward one picture, so here's the groups, right? So here's the superior group right here, anterior, posterior group. We go back. It's a matched kind of individual. Each group is relatively well developed. And you can see like some of the important veins over there. Now, if we go up forward, that's the other idea that we use, which is the idea of putting the brainstem, cerebellum, and fourth ventricle into the picture. So you can kind of like overlay them like this. And now I think when you do that, it helps a lot in understanding like where the veins are if you don't have cross-sectional imaging. So here, for example, if we go back, right, go back a couple of views, if you look at this line, right, look at this outline right here, that's the outline of the brainstem, right? So here's the pons, the belly of the pons, interpeduncular fossa, interpeduncular vein. Over here is something called the anterior ponta mesencephalic vein, right? So there's a mesencephalic aspect, that's the pontine aspect, and that goes down, and that's continuous with the anterior medullary vein, that's the medulla here. You see like a little bit of a thickening here compared to this. This is the cervical cord, anterior cervical cord vein, posterior. Here's the medulla, and that goes up. That's the pons, and that's the mesencephalon. Back here, you have the precentral cerebellar vein, and so that is, again, that's in the quadrigeminal cistern. So that marks the posterior border of the brainstem. There's the mouse. So you can kind of imagine the quadrigeminal plate's going to be sitting somewhere here. The lateral mesencephalic vein, which is very faint here, but that's this like structure here. So that would be kind of like sitting where the lateral mesencephalic vein sits. And then finally, over here, you have these veins. So in the frontal view, we've kind of been concentrating on the lateral, but in the frontal view, you can see the same structure. So here, it's a steep view, it's a Townes view. So in the Townes view, what you try to do is you try to kind of open up this area. And so what that happens is the brainstem veins, the anterior pontomesencephalic vein, then projects kind of inferiorly. That's the structure right here. This is the precentral vein is this thing here. Trust me on that. That's the precentral vein, and it kind of splits into these two. You see how there's like two of them here? And so that splits into these two veins that run along the superior cerebellar peduncle. These veins coming up from below over here and over here are the veins of the lateral recess of the fourth ventricle. And those are basically, we'll show them a little bit later. So they're related to the drainage of the choroid plexus of the fourth ventricle. And they're coming up here. And these are the Petrosal veins. So this group is the Petrosal, the anterior of the Petrosal group. That's draining in this particular individual in the superior Petrosal sinus right here. Of course, they're superimposed here. There are two superior Petrosal sinuses here, right and left. So right, left, draining into the sinuses over here. Okay, so that's, you could look at it that way. In the posterior group, of course, we have like, so this is a Vermian vein, the superior Vermian vein, which in this case is draining towards the torcular region. These are some inferior cerebellar veins. You can see them here and here, these two, and those are coming up also posteriorly. One very constant feature of posterior fossa veins that we're going to come back to that has a lot of important implications is how these, particularly these posterior group veins, are going to drain and how they're going to join the sinuses. And they do it in more often than not. These veins don't directly join, in this case, the transverse sinus, right? They go into this structure. You see how there's like this funny sort of flat line here. And there's, if you know, this is not so apparent here, but this is a good example in this individual. There's this little line, right? That line is a tentorial sinus. So these veins don't directly drain into the transverse sinus. They will drain into a segment of a venous sinus in the tentorium cerebelli, way more than 50% of the time. And that's called the tentorial sinus. We're going to come back to that because you're going to see this again and again, and it's actually is important. It's like a little quirk maybe, but it's an important, has some important implications. So again, here we go. This, right? Here's another one, another individual. Now this is another concept that you obviously need to know, and that's that veins are opacified in sequence. When you take your angiogram, in the early venous phase, you kind of tend to see more of the parenchymal veins of whatever parenchyma you're injecting. And then that's the image on the left. The image on the right, in the later venous phase, there's less of the veins of the parenchyma, but you see more of the venous sinuses, right? And so right here, again, what's this? Superior Petrosal sinus. This is the Petrosal vein, so this is like kind of a major or a little bit prominent Petrosal group. On the right, that's the Petrosal vein on the left, and that's going to drain in a different way. So this is the superior Petrosal sinus is a connection, right, between the cavernous sinus and this sort of like sigmoid, like sort of distal sigmoid sinus area. And so on the right, the petrosal group drains into the superior petrosal sinus that extends posteriorly towards the sigmoid sinus. On the left, the opposite thing happens. The petrosal group is extending anteriorly towards the cavernous sinus, the back of the cavernous sinus, which is here, and is draining out via the inferior petrosal sinus that you see right there. Okay, so all of that you could just basically you kind of put together like this. Right here you see all these sinuses. You see the blush of the lateral ventricular choroid plexus. That's a relatively constant thing too. That helps you identify where that is. Again, you see this line. You see this line. So these lines, these are your tentorial sinuses, right? Sinuses of the tentorium cerebelli. The more you look, the more you're going to see them. And they have the same, like sinuses, they're flat, right? So like they're located in between the two layers of the dura. And so they have this flat appearance, like a line when you look at them like edge on. Same like this petrosal sinus might look, right? That's the same thing. It's like you're looking kind of at the edge of that. And then, of course, you have this like whatever, jugular veins. These are these posterior condylar veins. I don't know if Frederick is here today. Frederick Clarencon showed some like really awesome fistula last week. Related to this, we have to touch on this area a little bit more, maybe in a different lecture, because that stuff, we really don't talk about too much about the venous anatomy of these veins, but good to know that. So anyway, here's the lateral of the same patient. Frontal view, that's the lateral view. Same stuff. Look, this is the petrosal group, right? Petrosal group draining into the superior petrosal sinus. So one of them is right, one of them is left. You have to work that out on your frontal view. And so here's the superior petrosal coming inferior petrosal. That's the lateral mesencephalic vein right here. So this person doesn't have a big anterior pontomesencephalic vein. You can see the shadow of that. But there is, you know, in balance with that, there is the lateral mesencephalic vein here, which is this thing over here. And, you know, so here's your like interpeduncular fossa, central vein. In the back here, you got them, you know, inferior cerebellar veins. That's the big one over here. You know, straight sinus. This is another one. So here, guess what? You got another like dural channel right here. So these veins, these are, you know, medial sort of like parieto-occipital veins draining into a dural venous channel in the falx that's connecting to the galen right there. You see that? So, okay, another person will, you know, again, like repetition, this is how you learn. So in every case, you want to see the stuff. So this person has a very good outline of the brainstem here. Again, mesencephalon, anterior pontomesencephalic, anterior medullary, anterior cervical, posterior cervical, precentral, right? Not so many, not a big like confluent group posteriorly, but this person has a big petrosal group. So Petrosal veins, these are veins of the lateral recess coming up to the petrosal system, draining predominantly anteriorly towards the cavernous sinus, out the inferior petrosal sinus like that and like this, right? And that's the brainstem that you want to put in there like that to help you understand how this is put together, okay? The other thing, so the concept of these bridging veins is, I don't know, like this, there are these veins. So basically like you have this, so here's a picture, a blow up of anterior. So this is the pons, right? The interpeduncular. So there's the, like whatever, interpeduncular area, anterior pontomesencephalic region, these tributary veins here. And then they're connected to the back of the cavernous sinus via these bridging veins. Now, there's nothing particularly special about bridging veins. The petrosal veins are bridging vein too, right? Like all of these veins at some point have to like leave the, you know, the brain, surface of the brain and join some kind of sinus, usually. So that's like a bridging segment. Goes by different names, but you want to kind of pay attention to these veins. Sometimes that's the principal vein, the way that they drain, instead of, say, going to the superior petrosal sinus and finding the way to the cavernous sinus that way. Okay. More on the tentorial sinuses. Again, like we've covered that a lot in the for the posterior, the galenic group, but you can have them anywhere. So here is a person, this is the basal vein, right? You can see how this basal vein, instead of coming up into the galen, happens to be going to like join the straight sinus, but it does it in a little bit of a different way. It doesn't, you see this flattened sort of channel here? So this is the basal vein. The black arrow points to the mesencephalic segment of the basal vein. And then at some point in time, it's going to connect to a sinus, a tentorial sinus, and that's the tentorial sinus segment. Now these, again, we'll cover the importance of that a little bit later. This is the MRI of the same person. And when you look at the MR, it's actually not, like a lot of times it's easy to appreciate how that happens. So the black arrow again points to that mesencephalic segment. So that's the basal vein per se. And then the white arrow, when you look at that arrow, you see how this is a little bit like thicker right here. And so here is, again, the black arrow in the coronal view. Here's the, like the tentorium, right? So this vein is running right next to the tentorium, but it's round. Now here you see how it becomes flat, right? So that's, at that point, that's the tentorial sinus, the typical flattened appearance. Okay, so more of that, more of these things over here. A lot of veins is whatever. I think we'll skip over like all of these veins for a later time perhaps. But again, like if you look at this picture, same thing, like always the same, you're looking at the same structures. Lateral mesencephalic vein, tributary, so this is the vein of the lateral recess coming up to the Petrosal vein, anterior pontomesencephalic vein, precentral vein, superior vermian vein, and so forth. So that's how that goes, right? Yet another tentorial sinus over here. Here's another example, more and more. We're gonna show, like, I know we're showing a lot of the same thing, but that's how you learn. Like every time you look at these structures, these flattened things, tentorial sinuses. So here's a nice example of a precentral vein, superior vermian vein coming up together, right? Okay. Now we're going to switch gears a tiny bit, and we're going to show, I want to do what I kind of told us we're doing. So we look at the MR or CT, and then we put the angio side by side. So I want to show a little bit of that. And it's a nice way to do that because in Zoom, you can just show images through the packs. So let's see if I can share this screen. Okay, so now you're looking at a screen of an anonymized patient. And so what you see here is basically like a volumetric post-contrast MR, T1. Standard thing, when you get these volumetric images, you get to see a lot of veins in them very nicely. And so the frontal and the lateral view of the same person's angiogram is here. And you can go and you could like identify similar venous structures. So if you come from the top, here's the internal cerebral veins. Now we don't see them very well over there, but you do see these veins that drain the choroid plexus right here. There, you see this dot, so like you're looking end on at these like veins over here draining the lateral choroid plexus. Now when you're coming down, so here's the confluence of the internal cerebral veins with the galen. Moving lower, you see right here, behind the quadrigeminal plate, you see this structure here, that's your precentral vein. Precentral vein is here. Now that's gonna split into a couple of veins that's gonna go down to the, like here, they're going down to the superior cerebellar peduncle at this. And so if you go down, here, of course, you have the arteries as well. So you have your MCAs, here's your basilar tip. Now, as we're moving down, moving a little bit down, you start to see right here, you see these little things? those are bridging veins. So the bridging veins are right there. You see those two veins here? That's the same thing. These are bridging veins. These are the same veins connecting to the back of the cavernous sinus in this particular individual, right? So that's the anterior pontomizzen cephalic vein. It's a little bit faint over here, but that is this vein right there. It's a little bit hard to appreciate, but you know, you're going to find it kind of usually behind the basilar. Now here is the petrosal group. So these petrosal veins are coming into this area. If I go up a bit, you can kind of see very faintly these. You can't really see these very well over here. They're really faint. Down here, you come down here, you see in this area, these veins here. This is the lateral, the veins of the lateral of the recess of the fourth ventricle. Also, I think in the surgical nomenclature, that's the cerebellum medullary recess or cerebellum medullary fissure right here. And so these veins here are right there, and you're tracing them coming up to the petrosal group, okay? Posteriorly, you see these inferior cerebellar veins. Now, if you go from below, you look at these two things, right? So here you see how the right one is a little bit closer to the midline, left one is like that. So this is it, right, left. You're gonna go up. Now look at these, look where they insert. When you look at them, you know, we're talking about these sinuses, right? So here, if you switch to here, you see how they're coming into the structure, which we're saying is the tentorial sinus. Now, what does that look like on MR? When you look at these veins, they're coming up. Now look where they go. So here's the sinus, right? Now, you see how the vein is not inserting on the sinus. The vein is moving a little bit more anteriorly. And this one is like considerably more so. Coming up here, coming up here. And you see where this one inserts? It inserts basically on the tentorium. And so does this one. You see that? So that's the appearance of the tentorial. That's how you can relatively easily pick them out on MRI. And the more you look on MR, the more you're going to appreciate like lots of other ones. Like here's another one. So here's a temporal vein on the right. From the anterior circulation injection, you would see that. So that's inserting on a little tentorial sinus segment over here. And then these ones have like a short one over there. And so basically that's like the more you look, the more you're going to see of those. Okay. So I want to show one more case. Again, we're just going to review, like, look at one more case of MR and angiocorrelation. Let me see if I can find that. Okay, this one. This is a very, very interesting case of a person with pulsatile tinnitus, a very unique cause of that. We'll do that at some point in time later. Not in this lecture maybe, but when we talk about pulsatile tinnitus. So let's set that up like this. All right. So here's the venous phase. Here's the venous phase in the lateral view like this. So what do we have here? In this individual, we have a big occipital. Oopsies. So we have a big occipital sinus, right? So here and here is the occipital sinus. And again, like this sinus, the occipital sinus also is very flat. And so you see how it's faint but wide in this view, and it's kind of like narrow in this view. The occipital sinus is right there. And so in general, the features here, again, this is the superior vermian vein, what's called the superior cerebellar vein, because it's continuous with the lateral Mizzen. It was the precentral cerebellar vein, inferior cerebellar veins. These are like the petrosal group here. And so again, mainly I wanted to show this so you could see the occipital sinus. Here's another, here's a superior. So this is a supratentorial dural venous channel in this patient as well. Here's the, so this is the posterior cerebellar vein, inferior cerebellar veins. You look at them, you see how they bypass the sinuses, and they're inserting on the tentorium. Here are your, so right here, you see these, this is the anterior Mizzen cephalic vein, right there, right here, coming up. These are your, so this is the interpeduncular fossa, interpeduncular veins, or posterior communicating veins. You can call them that as well. And so these are right here. And I think that's, in the interest of time, we're not going to go through this too extensively. But basically, the exercise of looking at the MR and the angiogram at the same time is a very useful one. Okay. All right. So now we're going to move on to some practical applications of this, or maybe, if at any question at this point, why don't we interrupt a little bit? Any questions about like the practical anatomy, the basic anatomy of this? Mohammed, hi, can you just point out some superficial and deep veins? I think we've done some of that. Let's see. Okay, so what we'll do, if you have any questions, comments, whatever, you could type them in the Zoom chat.
There's a question. There's a question from Dodi. What's the difference between a tentorial sinus and a tentorial meningeal vein?
I don't know, Dodi. Why don't you unmute yourself? I'm not sure. What is a meningeal vein?
No. Hello, everybody. Sorry for being always on the stage. My question is, can you hear me?
Yes.
Okay. So the difference between a vein and a sinus, I think, is that the sinus is kind of a collector of numerous multiple veins. And I think that in the tentorium, like in all meninges, there are arteries, like the meningeal arteries, and veins, like meningeal veins. So if a brain vein reaches the dura, then it enters into a meningeal vein, and then it goes into a sinus. So for me, the difference is between just a normal vein of the tentorium, which is, of course, the meningeal vein, and a sinus, when you could give it like more importance. It's something which collects multiple veins. And I don't think these are just veins going towards the sinus, and at a certain point, they will enter the dura like most cerebral veins do before entering a sinus. That's just to keep it things simple.
Okay. I think so Dodi, so I guess sometimes so definitely sinuses would be like rivers, right? Collecting multiple veins. So sometimes we do see that angiographically, right? Or an MR, like some of those things you can see how like several veins would be coming into a structure. But does a sinus have to, like by definition, if let's say you have like a basal vein or one of these veins, and it just happens to be that this vein, like instead of going into like a transverse sinus, it first reaches the tentorium, and it has a segment within the tentorium before, like, you know, like a river, like going into some other bigger, you know, structure.
Yep.
Like, do we call that, we still call it a tentorial sinus or no? Because it is, if it's in the tentorium, like, is that a tentorial sinus? Now, of course, there are like veins that drain the tentorium per se, right? Just like whatever veins for everything, as you say. But I guess for me, like whatever vein, if a vein is coming from somewhere else, like from some brain part, and it's connecting or reaching or somehow like is inserting on the tentorium, whatever segment of the tentorium then receives that flow would be the tentorial sinus. That's how I understand it, but I think it could be, I don't know.
May I? Can you hear me?
Yeah, yeah.
I mean, we have to add in the definition that the sinus it has to be like in between the layers of the dura mater. So I believe that we can have both things. We can have a vein like adjacent to the tentorium, but not a sinus because it's not between the layers. Or if it is in between the layers, like then it's a sinus.
No, but probably it's not really important. But just for being clear, most brain veins, cerebral veins, will enter a sinus, not directly, but before entering the sinus, they are covered by the dura. They're inside the dura. So this segment of vein, which is inside the dura, and you can show it in any vein, brain vein, well, this segment can be longer or shorter. I don't think that it really matters. And you call it a sinus if it's longer, and you just call it a vein if it's shorter. So to me, it doesn't make any difference. It's just a vein which enters the dura before entering the sinus, which is always like this. In every vein of the brain will enter the dura before entering the sinus. When it's in the tentorium, it's tentorial. But if it's on the superior sagittal sinus, it's up there. So I don't see a big difference. And I wouldn't call it a sinus because of a confusion that it might add to the fact that sinuses are big things, are important things, are things where a lot of veins go into. And the other things are just veins. But I know it's not important. It's just to keep things simple.
Dodi, thank you. No, this is great. Like, you're absolutely. Yes.
Although it does raise an interesting question, Kem, here, if you don't mind, Dodi. So
yeah.
Let's just take the example of the basal vein of Rosenthal example, where Max shows the basal vein, instead of emptying into the vein of Galen posteriorly, it enters into a vessel on the tentorial surface. And then it's kind of a straight vessel. And it's a flat vessel. And it's kind of an atypical connection of a basal venous segment to a tentorial venous structure instead of the vein of Galen. So the question I think you are very eruditely asking, is that venous structure, which is straight and flat, a typical meningeal vein, or is it an unusual venous structure, as Eitan is suggesting, perhaps in between the leaves of sinus, of tentorium, that distinguishes it from a usual meningeal vein, much like, say, the medial occipital sinus that is up there on the screen right now, which is not consistent. I mean, this is most of the time hypoplastic. We don't see it so much. You know, and so it's a very interesting question, and I think it would require us to really understand the fine anatomy of this venous sinus, or this tentorial sinus that Max is calling, and is it distinguishable from a meningeal vein? And I don't know the answer to that.
Okay, thanks. Enough of that.
Is it enough? I don't know. Now I'm fired up. I want to show some.
I agree. I don't know if it's enough. I think we need an answer to this, because you're espousing a doctrine here, and it might be that Dodi is correct, that what we're seeing is that a meningeal vein is capturing a cerebral vein, and I'm just not sure. You know, one thing I was going to say as you were going through this lecture is, you're labeling things tentorial sinus as if there is like a structure that we occasionally see in a specific location, and that's not true, because they can be anywhere disposed over the tentorium. And that might sort of suggest that it's a meningeal vein that has captured this. The sort of straight appearance of it, though, makes me think that it might be different, though, than the usual meningeal veins over the tentorium. I don't know. It's a curious question.
I don't know.
But maybe we need to look into the anatomy books and find an answer for that.
So, I mean, yeah, I guess we could. So, I don't, Kim. I guess it's a question of what it comes to definition, right? And the practical applications of this. I'm trying to show this.
Well, at first I was thinking that maybe it was just a definition, but now I'm wondering if it's more than a definition.
Well, so Doty's point is all veins have to at some point go through. So there's a bridging vein segment. There's a segment where they go through the subarachnoid space, right? And then they have to traverse one of the layers of the dura to enter the sinus, or somehow they have to get in there, right? So yeah, it's just a question of how long that segment is. But I just want to show, again, I guess since we're fired up on this topic, it's not obviously it's not the tentorial sinus thing. And I also have it just has this name because there's just so many of them there. There's just so many instances where these veins, these cerebellar veins, don't, they drain into what is really some segment of the tentorium that then connects to the transverse sinus. And that could be long or short, and there's no magic number. But it does, and I think it's more highlighted in surgical literature because it has surgical implications. If you're cutting the tentorium, you cut one of these big ones, you can end up with a venous infarct or a lot of bleeding. So I think that's what part of that is. And also because they're pretty common there, whatever we want to call them, this venous arrangement. But it's not unique to the tentorium. So here is, we see we're putting this together. Then so we have a lot of these examples of that. So here's a person with, it's not really a labet, it's just some giant vein that this person has. But this is before, again, it connects through this, there's a segment here that you see how it's flattened. And this segment, the connection between this segment and whatever you're going to call that, the transverse sigmoid junction, this is running in the dura, and we can call it whatever, but this segment is running within the dura, and you can see that on the angiogram, and you can see that on the MRI. So here and here you see that flattened transition here, right? And there's many ways. So, and the more we look, the more we see.
So Max, let's just stop with that one example. So this is where you would say this is an accessory dural sinus.
Okay.
The question is is this just a typical meningeal vein that's enlarged because it's accepting the cortical veins, or is it unique and it's not just a typical meningeal vein?
I mean, that question.
Do we have an answer? Because I think that's really what Doty is raising.
I don't think we have an answer, do we?
I don't know. I would like to.
I mean, you could.
Maybe we have been a little bit sloppy in just calling these sinuses, referring to these as sinuses, and what we are implying by sinus is just a hypertrophic meningeal vein that has collecting cerebral veins in an atypical way.
We would have to pose that question to the pathologist then, right?
I guess.
Have enough resolution to understand it.
Maybe.
What would be?
How would you distinguish it from a meningeal vein?
Yeah. What would be the difference?
That's what we.
Is there a difference? A middle meningeal vein, the tram tracking of these things that we see, in norm, is there a difference? Is that how meningeal veins are anyway, right? Or going back to that falcotentorial Doty, right? Those all these channels in the folks, like they're no different from in appearance than from this, right?
Exactly.
They look at like these lens-shaped things. So maybe that's just how meningeal veins are, right? There is some literature on dural fistulas, like surgical, like people like cutting up like excisions of these like fistula segments, looking at these like sort of like, they kind of look like this, I think, histologically. They have these like lens-shaped like channels, right? That then the histologists call them veins. They also stain them for veins. They list some stains. But I mean, the other question, so to go back to
Well, I mean, the bigger question too is like, how do you distinguish a sinus anyway from a dural vein or a meningeal vein? Like, is the superior sagittal sinus just a characteristic meningeal vein, or is it something more than that?
I mean, I don't think we know. We do. We know. I mean, we know like there's some hemodynamic. So go back to the hemodynamic versus genetic, or like this whole, well, not versus maybe, but in that discussion, like the bigger the vein, the bigger the brain vein, the more likely it is to have this, I don't know, we call them meningeal vein or dural channel or whatever. The more likely it's going to have this channel, and probably that's on hemodynamic basis. And like, why does the superior sagittal sinus form at the reflection of the sinuses? Probably it may also be for hemodynamic basis, but that goes into another topic, right? I don't know. So should we keep going, or?
Well, my hunch is that there may be a difference, and I'm just not sure. The only thing I can think right off the cuff is like the classic falcial sinuses that develop during embryogenesis.
Yeah.
That classically kind of regress. Now, I don't know if they regress all the way, or do they become just sort of, Fowlkes meningeal veins? I don't know. Yeah.
I mean, could it just be, it's just another channel. Like there's some hemodynamic reason why, an anterior spinal artery, the radicular medullary artery forms at this particular level versus another, right? Or codominance of them. I mean, the same process could play a role here. You
Okay,
just have
so
like the
maybe we've identified a project here.
I mean, but we know, like, so we'll get from the practical perspective, and this is what like Ryan is on the Zoom chat. Ryan is saying thoughts and discussion relationship of these things to the pathogenesis of Conyard type 3 dural AVS, right? That's exactly where we're going. Right, that's exactly the point. Like that, there are practical implications to the existence of these channels. It's that these channels can be involved in dural fistulas. So anyway, we're gonna. So this is just more. I don't know if you could see the screen, but there are many ways. Like we can. I mean, the imaging that we have angio imaging, we have like, I don't know, let me see examples of that. So here's a Dyna CT, the same channel. So here you see that on MR. Dyna, like we can take this far now, much further than we could before, but it's not to the histologic stage, which is, I guess, where that might be resolved. I also wonder, like, we might know more about this than the histologists do, or the pathologists, because there's not too many people interested in this topic. Okay, anything else? Brian, banana database. Okay, that's okay. So I mean, that's a project. That's one of the things that we could think of working on. All right. So let me show in along these lines. What I want to show is exactly like we're jumping into that very thing. Let's see. Okay, so can you guys see this? You can see the screen with the bleed in the cerebellum, yes? Right? Yes? Okay. So again, like, this is a, so just a couple of examples, and we kind of been getting to that already. So here's this person. Here is the angiogram of this individual. You see arterial, whatever, venous phases. Obviously, like, part of like understanding is you start to appreciate that there's a lot of venous congestion over here. And then you can kind of like want to put this together so you don't have a transverse sinus, or maybe a little bit. You don't have a sigmoid sinus here that you can see. There's a lot of congestion. The congestion is resulting in, like, you see how well you see the anterior quantum is in cephalic vein here. Now that might be just because how that guy is, or girl, but probably not. The reason it's probably more prominent is because stuff is trying to decompress from here, trying to find ways out. And again, like in general, like we talk about this all the time, if you don't see a structure, there are several possibilities. Number one, you didn't inject all the vessels. Maybe you'll see it when you inject the left carotid or something. Now, just give me 1 second. Okay, there have been some, can you see the red light? Because apparently there've been like feedback about the laser pointer. I hope this is better. Let's try this, see what happens. So, okay, going forward, this is the lateral view of the same person. Now in the lateral view, of course, you're superimposing the more normal right side on the left. And so it's not like as different. But you can see that there is, like, you can see there's congestion here. Here's your anterior quantum is cephalic structures. And so here, okay, again, like you inject the left carotid, still don't see the sinus. So two possibilities arise from that when you've injected everything and you don't see it, or I guess three. One is it never formed. Two is it's closed, thrombosed, or filled with something. And three, something else is using it, right? Some other whatever is using it, and that usually is a dural fistula. And so here is the lateral view of the same, and that's the external injection. So the external injection shows a dural fistula, obviously. So here's whatever occipital. The usual suspects are feeding this sigmoid sinus dural fistula, but it's a little bit unusual in the sense that I think sigmoid fistulas rarely produce bleeding in the posterior fossa. That's what I wanted to show this case, because it's a little bit different. Most of the time, when we talk about like the classifications, most of the time when there's a trapped sinus like this, and I think it is a trapped sinus kind of fistula, the fistula is intimately related to the sigmoid sinus itself. And usually when it's like that, typically what suffers is like the supratentorial brain. But in this particular individual, it seems like there's no outflow upstairs, and so a lot of the congestion happens to be involving the cerebellum. Now here's another case, and so this is where we kind of move, like this is a different person, presents with this hemorrhage. And here, when you look at this, again, like whatever, this is your injections, there's nothing really that jumps to mind here. Looks like the sinuses are open, what's going on. This is the injection, so here's the external injection. And so this is a dural fistula. And this is the kind of fistula, so this is what we want to like kind of get back to. Where exactly is this fistula, right? Like, it's not a fistula that seems to involve the sinus. So here's the, whatever, like all these arterial connections to it. And then there's this tuft of something, these vessels. And then you see the structure here, and that's the superior vermian vein, right? The superior vermian vein coming up and draining via the galen into the straight sinus, right? So this is what we would consider a fistula that's located on the tentorium. Like this is, and we can, I think, discuss about that, but the most logical explanation, I think, is that this is a tentorial fistula. It's not directly involving the straight sinus or the torcular in this case, and it's draining into this vein. So that basically, so what is the hemorrhage related to? The hemorrhage is related to the congestion of the superior group and the lack of outflow of the brain of the vermian segment and the adjacent structures, because this vein is taken up by the fistula. I think, Eitan, this is your case from years ago. We have some, like, whatever, you can look more into it, you can start treating it. Essentially, like, this is during the treatment, one phase of the treatment. Here's the supply. There's supply that's coming from the middle meningeal system here. And so ultimately that allows us to catheterize it like that, more glue, and that's closed. Okay, so what is this? This is tentorium cerebelli case. Let's show one more case before we break. I will show a similar case of, let's see if we can do that. All right. So again, this is a patient that comes in with, this is months later following this kind of hemorrhage here. You see the residua. This was came to us by way of a previous treatment at a different place. And so at this point, when we look at this angiogram, you see that there is sequelae of previous treatment. It was some onyx material. And so let's see if we can jump into the relevant images. So here's a leftward injection. You can see, again, like there's congestion here. You see that? So here's the onyx, but you can see like the onyx has this look that it's kind of like it might not have reached the target because it looks like arterial. Here's the venous face, so there's the congestion. Now this particular fistula, and again, like I'm showing it because when you look at this picture here, this is the injection of the right vert. And here you see what's supplying this. So this is basically like a proximal, what ended up being a proximal onyx deposition that doesn't reach the fistula point. And here you see in the lateral view, obviously it's like a little bit of a hypoplastic vert. Here's the supply to the posterior meningeal system, the artery of the tentorium cerebelli, and that's coming up to the fistula here, and that's the venous drainage of the fistula coming through this cerebellar vein, ultimately decompressing into the veins of the brainstem. And that's the source of the problem.
Where is that vein? Because it goes like on the AP, it goes through and through the cerebellum. Like, is it like going through the recess? It's not a superficial cerebellar vein.
No, I don't think so. You see that vein here?
Mm-hmm.
Right there. And you see how it's like the whole congestion is really around it. So, I mean, there's all these other things that are trying to, I think all these other veins are basically trying to decompress the area. But the principal drainage is through this. I mean, we didn't cover like, there's a great case we could show, like how the homology of the venous system of the brainstem to the spine. Like you see all these like transmedullary veins, the transmedullary veins of the supratentorial system. I think this is right, like this is on the spectrum of that. What you look at transcerebellar.
And then drains toward the Petrosal vein.
Yes, I think so here. I mean, ultimately, it doesn't have good outflow. The problem is that there's like, it kind of goes to where the Petrus angle would be, but you see how, I'm not really sure that this is a direct like how directly it's connected. Kind of dynamic picture. Sorry, I think some people are unmuted. So, I don't know. Can you see that now?
Mm-hmm.
Oh, I lost my. Hold on a second. I'm sorry. Where is the damn pointer? Okay, there. So there's that vein. And the connection here is not very robust. Like part of the issue probably is that just like there's not like a very ready source of outflow. And that's what distinguishes these things from AVMs, for example. Like, I mean, this is like broadly speaking, right? Like you have an AVM that's been there for a long time. The AVM has its veins. And usually, like, even though the AVM might be a much higher flow shunt than this, the brain may be able to tolerate it for a long time because the veins of the AVM are dedicated to the drainage of the AVM, and the brain has its own veins. And then the balance, of course, is always like, we could talk a lot about how those things evolve and how it becomes unstable because of some venous stenosis or whatever. But fundamentally, like here, you have a shunt that's using a vein that is obviously like, assuming these are acquired shunts, this used to be some kind of brain vein, and now it's taken over by the fistula. I hope this still works. So, so here, so going back to this, right? Here's the lateral view of that. So it comes like, as we were saying, it comes to the petrosal group, but then the outflow, like it doesn't find the usual outflow that you would need. And instead, it's coming into these like lateral brainstem coming out that way. There's the frontal view of that. These are all around the brainstem. Anyway, so that's like but that's another example of what we would consider a fistula that's involving the tentorial sinus, or whatever we want to call them, but it's not a fistula, it's not a torcular fistula. It doesn't directly involve like what would be a major sinus. Whatever, so the treatment, so basically like, you know, ultimately this required catheterization of this, of the tentorium cerebelli artery in order to cure it. And this is the post right here. Okay, so let me stop the share. Thank you, everybody.
Max.
So, okay, so questions?
Max, can you hear me?
Yes, Tibor.
Hey, so just just one question. So you know, the issue is like if somebody embolizes a fistula or some kind of a vascular lesion that involves arteriovenous shunting. In this particular case, for example, did they do a control angio from the vertebral artery after the onyx injection? And was it one of those where it was very, very small remnant and it was, the feeling was that it was going to go away, or was there an understanding?
I think there was understanding. It's in deference to the group, like, you know, it's a very nice group. I think, you know, I have the details of that, but yes, they did. I think what happened in the beginning, I mean, from a technical perspective, I don't want to show all the pictures, but essentially, like, there was a very easy way to kill this. And the easy way to kill this was to come from the middle meningeal artery on the left side and use a pressure cooker or use a scepter, or, I mean, people have these other double lumen balloons, and just push the onyx forward. The mistake that's made with these is that people come there with some kind of like, there's no control over reflux. And so it's an Apollo, whatever, some other catheter, and you just start injecting onyx. just hoping that it goes forward rather than backwards, essentially. Like,
Yeah, I see.
I mean, we can talk the technique, but that's the problem. And at some point in time, it goes backwards enough that you've sacrificed a good feeder. And then it goes to the other one and the other one. And the usual thing, I mean, as you know, like you take care of the good ones and then the ones that are left are bad or hard, like, you know, whatever, progressively harder to get into. But a lot of these, I think these tentorial ones are relatively, like there usually is one good feeder. It's just about getting, as you know, like it's about getting a good.
It's a far reach usually, yeah.
It's a far reach, but you have to have a good position. You have to have flow control. Like,
yeah, no, it's not easy. I'm not, you know, and actually I just recently discovered the advantages of having a balloon microcatheter, you know, creating a plug and, you know, preventing reflux. So I'm not saying it's easy. Okay, thanks.
Cool. Okay. Okay, anything else? Any other questions? Okay, great.
I have one question, Max. I still am not clear. It's been a point I never understood. What is Petrosal about the Petrosal Vein? Where does the name come from, or what? Where? It's a mystery to me.
I don't know.
Trostle Vein.
Does anybody want to comment? Anybody know?
I should probably have asked Kim many years ago, but I was ashamed because I thought I was supposed to know it.
Petrus bone, Dodie says. Okay, maybe. Anyone else? Petrus bone.
So,
Petrosal surface of temporal bone from Ryan. I guess we have the answer, right? I mean, it is related to the petrosal bone. Okay. Okay, cool. We have, so let's see, Dodie, you have a case. We have a couple of Eitan, you have a couple of cases?
Yeah, I have at least 1, 2, or 3.
Okay, so let's see, we have 9:16. So anybody, Eitan, do you have to go soon?
No.
Okay. Dodie, if you are ready, do you want to show your case? Or if
sure, but I can wait for anybody else. I don't want to be the first.
Why don't you show yours? And if anybody else has a case, like anything that's interesting about anything that's related to the posterior fossa venous system, would be the time. Now is the time.
Okay, Max, maybe I can go first.
Oh, okay.
From here.
Yeah.
Okay, just some slides.
Thank you. Thank you, Kitty Pong.
Start the show. Just to start the show. Shoot, I have to go back. It's not really cases, but just to show some of the anatomy.
Okay, cool.
Okay, I think this one is it. I think you've shown some of this in your slides already, but just a few more additional slides just to stress the importance of these things. Okay, so we've called bridging veins, especially those ones that are attached to the superior petrosal sinus. Okay, they connect the supratentorial veins also to the posterior fossa veins. But there are those, I think you've seen similar ones. So we do also this volumetric MRs enhanced. And yeah, I've noticed you're doing the same thing. We do fat suppression to remove the fat from, it will be too white on the MR, just to erase the fat in the bone marrow and all the stuffs. And once you have that, you get better visualization of the veins. And again, usually we see this attaching to the cavernous sinus. And sometimes not only to the cavernous sinus. I think this is another case. This one is a little bit, oh, this is the same one. So it is probably attaching to the anterior pontine vein to this one. And another case, similar one. This one is more, it's not at the cavernous sinus, it's a little bit lower. We can say this one is actually bridging to the inferior petrosal sinus. So these veins are actually, they're not that rare. You can see there's a paper published from a group from Bangkok. They found about 15% of the cases having these bridging veins from the posterior fossa, mainly the brainstem veins, to the cavernous sinus or either the inferior petrosal sinus. And if you miss them, like in this case, you embolize what you see as a shunt in the cavernous sinus, but sometimes you don't realize the residual reflux into the posterior fossa. You can have a complication like this. So these veins are quite small, but sometimes very important when you treat lesions in the cavernous sinus. And also, not very well known, like also, I've learned recently that we see a lot of these too. This is very difficult to see. The bridging veins to the marginal sinus or the sinuses around these at the area like anterior condylar veins. This one has, I think it has another one attached to the cavernous sinus also. When we see a vein draining into the cavernous sinus, like the bridging to the cavernous sinus or the inferior petrosal sinus, is usually on the lateral aspect. They don't usually go into the medial aspect. I've never seen one draining into the basilar plexus. Maybe just we haven't run into those yet, but you can see this kind of veins that drain into the marginal sinus. There's another case here from a friend of mine. There's a shunt into, I don't know exactly the position of the shunt, the location of the shunt around the marginal sinus, or sometimes maybe around the condylar veins. And usually these kind of veins, you don't get reflux into maybe into the IPS, but usually not into the posterior fossa vein. But this one you don't see the reflux into the IPS or anything, but you can see there's some veins draining to the opposite side into the superior petrosal sinus. So it's bypassing the brainstem veins. So what's going on there? We look at the source image of this angio. So, okay, here it is. You can see this thing running into this, the veins of the medulla, and also there's another one bridging, I think, laterally over here. So this is how it got the reflux into the system of the posterior fossa. So the message is, if you want to try to inject like your embolic materials like onyx and everything into this venous pouch just to cure the shunt, sometimes you have to look for this, connections or your onyx might end up filling the system of the brainstem veins. And so we can summarize something like this. We can have the bridging veins, the cavernous sinus, also the inferior petrosal sinus in about 15%, they say. And these are some of the slides I got from another friend around the area of marginal sinus. Posteriorly, they can be posteriorly connected, laterally connected, and it's about up to 10% that we see this. There are very small veins, they're not very large. But sometimes it can be important when you try to do something around this area. And the last case I want to show you is kind of like the opposite of what Max was showing in his cases. There was a patient, usually very typical of the spinal dural fistula, okay? So they did, I got this from another friend also. They did the full spinal angiogram, but they couldn't find any shunt at all. So we were discussing what to do. And I looked through the source images of the MRs, and actually I saw this some dilated veins also in the posterior fossa. So the next time we did an angio of this external carotid and also the internal carotid, and you can see that the shunt was at close to this, probably near the you can say this tentorium, or maybe the area of the superior petrosal sinus, and it drains all the way, because it can either drain through the superior group to the vein of Galen, or through this petrosal group, or posteriorly to the torcular. But it doesn't, it lost all the connections probably, so that it needed to drain all the way to the spine to cause this, cord congestion. So the patient presented something very similar to having a spinal dural AV shunt, but actually the lesion was actually at this area of the petrosal sinus. Okay, it's just some okay.
Tibor here. Hey, thanks for showing.
Okay, hi Tibor.
This is super important for, especially for younger colleagues, but
yeah,
for me too, as a reminder, because when you embark on a spinal angiogram in a case like this, and that if you did the spinal angio and you find nothing, then you have to go higher, and keep going. And so I call it a complete neuroaxis angiogram. And I think we all feel the resistance once you did the spinal arteries, the resistance to keep radiating the patient and keep giving contrast, because what is the chance you're going to find something in there? Well, the problem is that if you miss it, it has significant consequences. So this is a fantastic thing to remind people of the importance of, yeah, you didn't find it, and yes, the chances are small, but you just have to go on and do injections of the externals and in the cranial circulation, because if you don't check, you're not going to find it.
Thank you. Exactly. Okay, pass it back to you.
Thanks so much. They're awesome cases, right? So I guess, we could, I don't know, probably, you want to maybe mention like the bridging veins, like that goes again into this homology with the spinal system, right? Like how does the cord, are they bridging veins? Are they radicular veins? I don't know what they are, but they are the weak link, right? That's where the weakness is between the cord veins and what's outside the cord, and that's what's really hurting in the dural fistulas of the cord. But here you have the reverse, right? When you take down the cavernous fistula, you just leave one of those little things alive, and it goes to the brainstem. Okay, any comments? Let's see, anything on the chat about Kitty Pong's cases? Okay, all right, thank you. Dodi?
Yeah, I'm here. You should allow me to screen share. Tells me that I'm not allowed, that the host disabled participant screen sharing.
Yeah, we see. Okay.
That's okay.
Okay, let's see if we can. Eitan. Let's see, Dodi, maybe, Eitan, you want to show yours?
Yeah.
You can get Dodi's
Yeah.
yours up.
Okay. Okay, this one. All right. I also cannot share.
Hold on a second. Oh, you know what? I'm sorry. This reverted. Okay. Dodi, can you try now?
Yeah, it looks like I can now.
Yeah. Okay, great. Thank you.
Can you see me?
Yes.
Okay. So this is a 40-year-old lady with a cerebellar hemorrhage. And it's quite similar to what you've shown a little while ago. This is sometime after the hemorrhage. And we go for an angiogram. And as you can see, there's not really much on the posterior circulation. There are artery injections. Even the veins, nothing strange. And then we go to the external, again, nothing. But when we go to the internal, we see this. So now this is pretty clear. There is the dural fistula at the level of the Petrosal Vein, which is fed mainly by the arteries coming from the siphon. So it's the meningohypophyseal trunk and the inferolateral trunk. And so now the question is what to do. Do we go through an arterial approach? But the arteries are just these, so we don't have any external carotid branches. The meningohypophyseal is very, very tortuous and probably not really, you cannot get a catheter there. The inferior lateral trunk could be better. It's not usually so easy to enter that trunk from the siphon because of the unfortunate origin. But so we decided maybe a venous approach would be better. And Dr. Luca Quilici was operating, and I had the honor to be with him. And you can see that the vein is coming. It's an interesting vein because it goes all the way from the Petrosal Vein around the cerebellum towards the vein of Galen. And so he could come from the opposite transverse sinus into the vein of Galen and into this vein. It was not so easy to pass this venous dilatation, which probably was the source of the bleeding. But finally, he could get over there, and reaching the foot of the vein, he could place a few coils, 2 or 3 coils, not more, occluding the fistula. This was the final and the CT scan. And the follow-up, of course, the 6 months follow-up with MR, and the 1-year follow-up angiographically with complete occlusion of the fistula. So this was before, and this was the 1-year follow-up. I thought it was interesting just to show that, you know, the connections of the veins and from the anterior part of the posterior fossa, you have this long vein going all the way back to the final, to the location of the vein of Galen. So that was pretty much what I wanted to show.
Thank you, Dodi. This is awesome. And thank you for this slide too. I have first of all, this is incredible. Like this, technically, this navigation into that vein is something that, you know, I would be personally very scared to do, and it seems like it was accomplished magnificently. One comment about like why it looks like that. I think it's likely that there was where you see that out pouch, that sort of like venous ectasia. Yeah, I think there was probably like another venous outflow that got occluded, and so the fistula found like a collateral venous outflow through this cerebellar vein. This is my interpretation on this image. And we know that happens pretty often with fistula. You know, the venous outflow gets occluded, and there's and you know that's also like probably Mac's case before of the tentorial fistula. It was probably the same thing.
It could very well be, yes, of course. We don't have the proof of that, but it could very well be, yeah.
Hema was asking what were the materials used for access? Do you know what?
I'm not sure I remember, but there was an intermediate catheter up into the straight sinus, and then from there it probably was a duo 156 catheter. So it's the small catheter which allows coiling, and that's probably the one. If it was not that, it was an SF10 catheter.
And what would be the wires that you would use for this?
We probably tried different wires, as we usually do, because not always the first wire you choose is the correct one. And in our hands, the wires that work well are the Synchro 14, the Traxxas from Microvention, or even the Azarki 10 or 14 are good wires. Sky. So I don't remember which wire was the final one, but sometimes you have to change wires during a case in order to get to where you want. Maybe one wire is better for the first part, and then you need a second one to access more distally.
Can I ask a question?
Awesome. Dodi, it's a beautiful case. And I certainly would have tried to give it a go, you know, endovascularly as well, you know, either transarterially or transvenously. But if it was unsuccessful, how willing were your surgeons to take care of this?
Absolutely. I completely agree. It's not a difficult case surgically.
Right.
It's like, you know, a pontocerebellar angle access. So, and it's on the dura, it's not on the brainstem, it's not on the cerebellum, it's just on the dura. So it's something that we certainly would consider. But today we tend to do these things endovascularly first.
Yeah, no, I totally, you know, I mean, it's, and the surgery itself is not necessarily completely trivial. I mean, yes, we do it, but it's, you know, the patient also had to bleed. You know, you may have swelling of the cerebellum when you open the dura, et cetera, et cetera. But, you know, in the acute setting, no question, it's, you know, endovascularly, you don't have any of those issues that you have to worry about.
Okay, thank you.
But beautiful.
I am quite worried about, you know, going through the vein. It's very different from going through the arteries, because if you have trouble, like you break the vein or something and you get a bleed, it's probably difficult to stop the bleeding, because if you're in the artery, you can embolize that pedicle and stop the bleeding. But if you're in the vein and you happen to break the vein itself, you're like doing things downstream. How would you manage to control the bleeding in case you break the vein? I don't have the confidence to do these kind of things.
I completely agree, Gittebong. It's a danger. I have to say that we have navigated veins like hundreds of times, I would say, both in AVMs and in dural AV fistulas. It happened maybe a couple of times that we ruptured the vein. Interestingly, the hemorrhage is pretty unimportant, meaning that due to the high flow in the vein, there is not a lot of pressure inside the same vein. And unless you completely occlude the vein, and then so the hole is the only way out for the blood, but if you keep the vein open, the flow will tend to go inside the vein, and being high flow, the lateral pressure is pretty low. And so we did not have as many complications as you would guess. Probably, I cannot remember one single severe complication due to rupture of the vein, even if we navigated really many of them.
Mm-hmm. I see. Thank you.
Of course, we have had complications because the vein ruptured after our treatment, like when you treat the AVMs and then you occlude a vein, then you have a rupture of the big bleeding. In those cases, yes, but it's a completely different story. It's not due to the catheterization of the vein. It's due to the outcome of the embolization.
Did you try to catheterize to the ILT, or you went straight to the venous?
It was not me, it was Luca. But if I remember well, he decided just to go directly to the vein. And we have tried a few times to catheterize the ILT. I must say, with not so much luck. So we were not happy of doing that. Maybe it could be easier if you place a balloon in order to help your catheter to enter the ILT. But that's a complex procedure. We didn't want to do that. So no, we went directly to the venous access.
I personally, if I may, I personally find in these type of situation, you have to distinguish between a petroclival meningioma that is supplied by MHT, where you just get a little bit of catheter in the origin. You can safely inject particles without refluxing into the carotid, because you're not putting a pressure on it that is gonna reflux, and you can see it. But with the fistula, what I find is that, and I had a case a couple of years ago where it was a very similar fistula, and went to the MHT, but couldn't get far enough. That's the problem with the MHT or the ILT, because even if you establish yourself a little bit, usually I have a hard time advancing the microcatheter enough so that you have a safe enough position for glue or for onyx. And so I thought I'll inflate a balloon in the internal carotid, in the cavernous segment to make sure that the onyx doesn't reflux. And sure enough, it refluxed back, and ended up having to put a stent in there because a lot of onyx came back into the carotid artery. So yeah, these MHTs and ILTs are very difficult in my experience to catheterize. I don't know if you guys agree.
Completely agree. Absolutely.
Yeah, I mean, we have a lot of experience with particle embolization from both MHT and ILT precisely for the reasons you say, Tibor, because you don't have to go far. And I think that particular technique is underutilized because people are afraid to put particles into those things. I think not for a good reason. Like you watch for reflux, but that's essentially okay. So don't reflux, right? And if you reflux, you stop. But other than that, there's not too much to watch for. If you come from other pedicles, not only do you have to watch for reflux, sometimes you have to watch for all these other anastomoses. Much more so than if you're coming from your quote unquote dangerous anastomosis. Well, that's,
Also, I've put a balloon at the orifice of the ILT or MHT while we're embolizing, so that way it prevents reflux, in particular for liquid embolics. That's a nice strategy too.
Right. It's great if you can do that, yes.
all right.
I would not inject particles to occlude the dural fistula, though.
No, I didn't suggest that.
No,
just to make it
sorry,
sure.
yeah, noted. Sorry. We're talking about meningioma, pre-operative of skull-based meninges, yeah. Let's see, Eitan. I don't know if Eitan maybe had to go. Let me see if I can show.
Can you hear me?
Perfect. Yes.
Okay.
Go ahead.
All right, screen one, share. Okay, do you see my screen?
Yep.
Okay, good. So I'm gonna show you this patient. Again, these are all. This is a fake name. Okay, so this is a patient coming in, like actually coming from another institution after he was followed for a while, and he had this progressive lower extremity weakness. Sorry, progressive like all extremity weakness, and he had a lot of cerebellar symptoms, and the MRI showing this abnormality in the brainstem. You see, like on FLAIR, there is this hyperintensity in the medulla and in the pons here, and a couple of microhemorrhages too in that location. At that time, this was interpreted as a demyelinating disease, like and treated with steroids actually. This is the MRI from that other place, and showing that showed also like some enlarged venous structures in this region. A CTA was also done, and the CTA is actually very, very good, because the CTA shows very well like an increased size of a vein that runs in the midline from the pons to the cervical spinal cord, which is the anterior pontomedullary vein continuing as anterior spinal vein. Now it's hard to say exactly where is the issue. Why is this vein increasing size? But let's see if, like on the axial CTA, like we recognize the same vein running in the front of the spinal cord, and then on the front of the pons. Now the findings, though, were pretty suspicious for a dural or an AV fistula or a vascular malformation, which was associated with edema in the brainstem from a venous congestion. So he came to us. This was last year, and we did an angiogram, and the angiogram on the first very image of the angiogram, like, we identified the issue, and here this is very similar to the one that Kitty Pong showed. So we have a common carotid artery injection, and we see this early opacification of this vein here, and the vein, this fistula is supplied by this meningohypophyseal trunk. ICA injection to understand this better. So we see here, we see this increased size meningohypophyseal trunk through the tentorium, like going along the tentorium and connecting here with a vein. We see here the start of the vein, and we see that the vein is connected inferiorly through the essentially through the Petrosal Vein to the anterior pontomedullary vein. So this is just a magnified view to understand better the origin of this, because I think here, like, it's a venous approach here is essentially impossible. So we wanted really to understand better the arterial approach to this. And this is just a panoramic view, which is excellent. It shows us where this vein goes. And as you see here, this is the artery along the tentorium, along the margin of the tentorium, going toward the superior aspect of the petrous bone, and then continuing with the vein, like here, like this, like going down through the Petrosal Vein and joining the midline, and here it joins the anterior pontomedullary vein, and that finds the outflow inferiorly and tries to get out of the cord here to like a spinal vein, a radiculomedullary vein. So I think we had some good 3D at the end, just to understand the like better, like the origin of this MHT, which is from here, and then yes, and this is the 3D image that shows like the relationship with the petrous bone. So now this is like a view like from posterior. You see like here, this is the internal auditory canal, and this is like the artery really running along the superior superior margin of the petrous bone. Okay, and this is the point of the fistula. This is the point of the fistula, and this is the vein that then runs down and then goes to the midline and reaches the anterior pontomedullary vein. Come for treatment, and the plan was to do a transarterial approach. So you see here again the right ICA. We decided to go with a big support catheter. I think it was an avian, and then this is like a headway duo, and with a little difficulty, the catheter made through, and but once it reaches this position, actually we didn't try even to go much more distal, because we were afraid to cause other issues, like to cause spasm or else that would have then prevented the treatment. So then at the end we use this as a position. We wedge the catheter. This is like the injection from that wedge position. You see this is like a lateral view, and this is the injection, and you see again the point of fistula is here. So we know that in order to treat this fistula, we have to reach this point, and this is the blue injection. This was MBCA, and this is the post MBCA injection, and the fistula is cured, and we don't have here on the anonymized folder, we don't have the follow-up, but the follow-up showed like resolution of the edema in the brainstem. Unfortunately, he woke up with a new 6th nerve palsy. Like in terms of understanding why that happened, if you see here from the position, you see this branch that goes down. This is likely the branch that supplies the nerve. Now the 6th nerve palsy resolved. So it was in a matter of 2 months. So again, like I don't have the images of the follow-up, but there was a complete resolution of the fistula and the brainstem signal.
Okay. Nathan, thanks. Okay, let's see. Any questions? Okay, question from Edgar. Mentioned the use of particles. It would be great to see a case with particles. I'm not very familiar with particles for dural AVS. Okay, Eitan, you want to answer?
Yeah, I mean, we wouldn't use particles for dural AV fistula either. I don't understand how this, like I was not connected before, probably there was a misunderstanding. We would not use particles for dural AV fistula.
General question, someone who is not familiar with particles.
Yeah.
We talked
I mean,
about angiomas, using particles for meningiomas, but not for fistula.
Yeah.
It's, I mean, generally, just for the group, generally speaking, particles are not effective for fistula, because a fistula is a hole between artery and veins, or a series of holes, and the particles, they don't tend to have a permanent efficacy with that. They tend to lodge, they either fly through the hole, or if they lodge somewhere like in the arteriolar or arterial feeders proximal to the connection, but they don't really seal the connection. And the connection, the idea is to seal the arteriovenous connection, or in case of a dural fistula, to plug up the connection from the venous side. So what Dodi showed is a transvenous treatment, and that just plugs up the common venous recipient pouch. And obviously the coils don't have to go into the arteries, but that treatment works very well for dural fistulas, because the foot of the vein is usually is in some dural segment. Doesn't work very well for AVMs, for example, but this sort of venous occlusion with coils or with whatever is highly effective.
Max.
Uh-huh.
Yeah, I just wanted to point out that yeah, so we don't use particles to cure fistulas. Before Onyx, when we used to have MBC as the only option, there was a strategy where you identify where you're going to do the glue injection in the end, and in preparation to pare down the vascular supply from other sources, you would embolize other feeders with particles and coils to shut them down, to increase the chances that you can permeate the fistula with the MBCA. But yes, it's important to understand not to try to close a fistula with particles.
Okay.
Here on the post CT, it's a DynaCT CT, but it shows like the deposition of MBCA, and it shows that indeed it reached the vein, and here is a little part of MBCA that went through the vein, just enough to close the fistula. And here the location of the fistula, again here, like on the picture's ridge at this point, that was the fistula point.
Eitan, just out of curiosity, did you ever see a superior petrosal sinus in this person on that side?
No, indeed, like one of the strategies I thought at that time was try to reopen it, because
Yes.
I think, yeah, so I thought about that before the case, but then it worked out this way.
Okay, good.
Yeah, but remember that in these cases, surgery is a very good option.
Yeah, and surgery, absolutely. Thank you for reminding too. Surgery was absolutely like on board. Actually, like we had the OR ready like for the day after in case we would not have been able to do this.
All right. Okay, thank you, everybody. Any other cases? Cases, comments? All right, let's see. Okay, it's 10, I guess. Thanks, everybody, for coming.
Hey, David.
Any announcements, anything else? We are, so next week is EMBA Club. Again, 8 o'clock. If you have any cases, please email us. It's neuroangio@neuroangio.org. If on the on the Banana page, you could see the email. If you have anything to present, we have some cases from last time that we're gonna be finishing up with as well. So if you have anything, you could add to the collection. We'll have this recording available of this session, as are all of the anatomy ones. And the other thing, the last thing I wanted to ask is, in 2 weeks, so we're kind of we're in June, and it's been a very different fellowship year for a lot of our fellows and fellows everywhere. But graduation is, at least for us, it's the end of June. So we'll have like a session in 2 weeks, and we'll finish up on the veins with some venous disease lecture perhaps. But we also wanted to ask, and periodically we'll be doing this, is we'll be asking you, whoever participates, particularly if you're in training, like what topics you would like to cover. We'll have a whole year of topics to cover. We'll keep going, covering, like we'll move to the arteries after this, like probably in the next month or so. But there's a lot of topics that are obviously of interest to people. So if you want, please email us, contact us with suggestions of what topics you want us to present. And then based on what happens, we'll put together something. So again, thank you very much for coming, and we'll see you next week.
Thanks, Max.
All right, take care.